Hello, and welcome to Beyond the Bylaws, the medical staff show. This is Husch Blackwell, LLP's podcast covering the legal and regulatory aspects of hospital medical staffs. We're focusing on the important but sometimes confusing world of medical staff legal issues. I'm Nick Healey, a healthcare regulatory partner at Husch Blackwell, and I am in my third decade of working with hospital medical staffs. Before we dive in, I'd like to note that nothing in this podcast constitutes legal advice, and the views expressed in this podcast are mine or those of our special guests, and not those of Husch Blackwell. Thanks for tuning in for part 2 of our medical staff bylaws episode. This episode is the one in which we cover more specific issues that come up in the medical staff bylaws, provisions that you'll commonly find in medical staff bylaws, drafting tips, ways to avoid common problems, and other fun topics. Okay, so let's actually turn to big topics that really should be covered in the bylaws. And we can go through these, and I just want to mention what needs to be in the bylaws, and then we can talk about specific parts of them. But one of the crucial parts I think we've already covered, which is, the priority of bylaws, rules and regulations, and policies. And I think we would all agree here today that treating the bylaws like, a constitution that contains the basic steps of processes, the basic qualifications for membership, the basic principles by which the medical staff organizes itself. And in my view, particularly some statement that recognizes and states the relationship of the medical staff to the other stakeholders, the really important stakeholders in the organization, administration, and the governing body. I've seen a lot of medical staff bylaws that don't have that. I always put that in. I think that's actually really important, both to remind the medical staff that there are other stakeholders, that they have a very specific job under the conditions of participation. They are delegated responsibility for the quality of care in the hospital, and that really is the context in which the rest of the bylaws flow. They all serve that purpose of ensuring that the medical staff can fulfill its obligation to the governing body to be responsible for quality of care. And I also like to put in there, that their relationship to the administration, and that the administration has a separate mandate from the governing body, that they're intended to be co-equal. And I'm curious, Ellie, do you tend to put that kind of a statement in there? Do you tend not to?
I don't know that, frankly, I'm glad we're talking about it because I don't know that I've been as intentional in the past of making sure something like that is in there, but I think it's a really good idea and I really like it. So now I will. I think I totally agree. I have seen a lot of issues in the past where medical staffs, there's just a confusion of how it's supposed to go. And like, what is the role and where, how decisions are supposed to go, and what everybody's relationship is to each other and why. Like, I've done a bunch of trainings to explain to the medical staff, like, hey, this is why it's structured this way, is because the Medicare conditions of participation. And then accordingly, your accrediting body, whatever it is, requires it to be this way. This is why we do it this way. And they're like, oh, okay. Yeah. And that context, I totally agree. Reading everything else within having that context and background, it's just really helpful to be like, oh, this is why.
Yeah.
So yeah, I should do that more. So thanks for the tip.
It's just been something that I've found has been really helpful. I mean, because I don't know that medical staff members, and particularly people who are tasked with reviewing bylaws, get a lot of training on exactly why they're doing what they've been asked to do. And I think it is actually a really important part. Melanie, do you guys do that?
I think my bylaws are pretty clear on the relationship between the medical staff and the board of trustees, but I think that's a fantastic idea to add some additional language about the relationship with administration and how all of those pieces fit together. I'll have to look and see if we can make some changes there.
One of the other things with respect to other stakeholders that has come up over the years is including some kind of, I hate to say dispute resolution mechanism when there are disputes between administration and medical staff, or administration and medical staff and the governing body. But is that something you typically see in bylaws? I put it in a number of bylaws. In some situations, it hasn't been important to the medical staff, but some kind of joint conference committee in which they can hash these things out, I think is a really helpful mechanism for that. I'm curious about, Ellie, what your thoughts are on that.
I think it can be helpful. I very rarely see it, if I'm being honest. So, like, yeah, I very rarely see it. California requires it. I remember doing a set of California bylaws at one time and looking at that, and they do require it. The Joint Commission has like a if the a requirement to have some sort of mediation body on disagreements over the bylaws or amendments to the bylaws or something. It's just very narrow, very specific. And I've never seen it be that helpful. So honestly, yeah, I think that it's rare when that comes up in my experience, but it does come up, or maybe not that rare, actually, now that I think about it. Disagreements between the governing body and the medical staff or administration of the medical, all of that, and some sort of mechanism I think could be really helpful, but I very rarely see it.
Yeah. Melanie, what do you guys do?
Yeah, I do have a section in the bylaws for conflict resolution. It's brief, and it does talk about if the medical staff and the board of trustees cannot agree on amendments to the bylaws, it's in line with that. It does talk about outlines a process for conferencing together, meeting together to see if they can work through it and talk through their differences of opinion on the amendments. I don't have anything in there about conflicts between administration and the medical staff, but that does come up, and it's probably a very good thing to add.
Yeah, I've actually also seen it triggered between for conflicts between departments as well as between departments and committees. I mean, an overall medical staff dispute resolution process between different elements of the medical staff. And I haven't seen it triggered very often, but I always think it's a good thing to include in there from a structural perspective. So just a suggestion, I guess, if anyone listening may be having those issues and needs a mechanism, that's one to think about. Okay, so another critical thing, qualifications for membership and clinical privileges. So here I'm kind of curious about your guys' experience with respect to how detailed you get. I mean, you need to outline the categories. Again, the Joint Commission requires that you have all of the categories of medical staff membership outlined, as well as the credentialing and privileging processes outlined. I'm curious about how detailed you guys get in the medical staff bylaws with respect to what the qualifications for medical staff membership are versus privileges in each category. So, Melanie, what about you? What do your bylaws say about that?
It still remains fairly high level at the bylaws level. It does. We go into some detail about, for example, like number of patient contacts that you have to have for each of the different categories, or who fits into each of those categories and why. Beyond that, it also talks about responsibilities and prerogatives, but it's more of a summary at the bylaws level, and then like the credentialing policy or the other documents that are governing processing applicants to make sure that they qualify are much more detailed.
Yeah. One of the big issues that when going through these bylaws drafting exercises, I still get some medical staffs that want to include some elements of privileges in certain categories. So you'll get, like, for active medical staff membership, the active medical staff membership category, you'll get people who want to put in that the right to admit patients to the hospital is a prerogative of active medical staff membership. I always discourage that because in my mind, medical staff membership is a political issue. It dictates who gets to be on committees, who's eligible to be an officer, who has the right to vote for certain things. And privileges are a different issue. And the right to admit is a privilege. It's not necessarily a right that goes along with medical staff membership. So I always try to separate those two issues in the bylaws. And Ellie, thoughts on that?
Yeah, no, I actually think that's a good perspective. And it's a really like detailed, nuanced one that you're not going to find that anywhere, right? You're not going to find that requirement in the COPs or the accrediting bodies requirements. It's like how things actually operate. So I like that perspective, actually. I hadn't thought of it that way, but I've seen a lot of questions come up about that. Requirements for admission and this and that, especially when you get to like physician-owned hospitals that are grandfathered in, that can be very touchy.
Absolutely, it can. I'm curious as well with respect to requirements for privileging. do you either of you ever include in the bylaws, or do you leave it for privilege sheets, any requirements for specific privileges, qualifications for being able to hold certain privileges? Like, and a couple of them actually, I'll give you just one example, is in a lot of bylaws they'll have that in order to qualify for privileges, a hospital or a physician needs to have an office within X number of miles of the hospital, which, having in the bylaws to me seems a little, as you said, Ellie, prescriptive, a little too detailed, because there are certain privileges that you may not need that with. And it also goes to whether you're required to, you have any patients in the hospital, whether you've made alternate arrangements to be in town when you have patients in the hospital, whether you're on call. So I'm curious if you guys still see that a lot, or if you advise including it. What's your thoughts on that? And Melanie, what do you think?
That one in particular, the distance from the hospital, that's addressed in a call policy for us.
Yeah.
And if you have to take call and you're responsible to respond within X number of minutes, you need to live within X number of miles. That's all in call policy for us. I have seen it in the bylaws before, not here, but I don't have it in my bylaws.
Ellie,
I think that's a better practice.
Yeah.
The way Melanie's hospital does it. I have seen it in the bylaws as well with a lot of clients, and typically, to use your term, what you just said, it's a more of a political, it's a gatekeeping thing that they like to have in there as a qualification rather than the call, is what I've seen.
Yeah. It does make me a little concerned with the increased scrutiny of the FTC on antitrust issues with hospitals, that something that is a condition of holding privileges at all would be, isn't necessarily isn't as related to patient cares as it should be. I'm probably explaining that badly, but it seems like addressing it in a privileging policy, or with respect to certain privileges, and requiring that if you have, people in the hospital, or patients in the hospital, or you're on call, that you have to be, able to respond within 30 minutes or something like that. That makes a lot more sense than requiring that somebody have a full-time physical presence within a certain number of miles of the hospital. I would wonder in some situations whether antitrust regulatory agencies might have something to say about those sorts of things. Ellie, do you have any thoughts on that?
I mean, maybe. I think they have bigger fish to fry than, frankly. So, but, potentially, if somebody really wanted to make us think about it. But yeah, I don't think people feel too sorry for doctors when it comes to all that. So I don't know, like I could see an FTC saying like, oh, you're just using that to block trade, which I think sometimes maybe is like an ulterior motive, but you can come up with legitimate reasons behind it. So
yeah. So, yeah. Okay. So we've talked about categories of the medical staff. Nurse practitioners and PAs are obviously a hot topic for the medical staff as a whole across the country these days. And I'm curious, I know that the COPs allow PAs and NPs to be members of the medical staff depending on state law, but I'm curious what you guys have seen. Do you see NPs and PAs allowed to be full members of the medical staff with the same political rights as physicians? Do you see them in a separate category with different political rights? Ellie, what are your thoughts on that, and whether they should be?
I typically do not see them as full members of the medical staff. In fact, I don't think I have any clients that have that. If I'm, being honest, I don't think any of them do. They're typically allied health professionals with a little bit more limited rights than full members. And whether they should or shouldn't, I mean, I think that just really depends on the hospital, and the dynamics of the hospital. And also, I'm not a medical provider, so I don't know that I feel like comfortable saying they should or shouldn't, but I can see it being tough in certain circumstances and dynamics. And then in other certain circumstances and dynamics, I think it's perfectly normal. I mean, like all workplaces, I think all hospitals have like a certain vibe and how things go there and things work. And whether they are given that position on the medical staff kind of depends on how they operate.
So I'm going to get...
Got careful enough?
Yeah, very good. I appreciate that. But you've you've also clued me into the first item of merch that Beyond the Bylaws is going to offer in our online merch store, which is a T-shirt that says Bylaws Vibes.
Bylaws vibes.
Right? I like that. I think that's great. Melanie, what's your experience with PAs and NPs on the medical staff? Yes, no.
They are not considered members of the medical staff here, but we did during that last big review. Our medical staff, they discussed it at length during that review, and they weren't quite ready to take that leap to make them members of the medical staff, but they did take a lot of steps to involve them further. We changed quite a bit of like what committees they can sit on and other ways that they can participate with the medical staff without being full members of the medical staff. And I think that our APP staff has appreciated that, being more involved.
Do you have them sit on credentials or peer review or on the MEC?
Yep. I don't have one currently on MEC, but the bylaws do say that an APP member may be appointed to MEC. I do currently have one on MEC and on our peer review committee, on our wellness committee, and seems like there's a couple of other smaller committees too that have APP members now.
I know that the argument that physicians usually make that APPs shouldn't sit on credentials or peer review or the MEC itself is that an APP or a non-physician shouldn't be in a position to judge the care provided by a physician because they don't have the same training. I think they would often say adequate training, but I'm going to say the same training. And I'm just curious, Ellie, do you hear that too?
That they have the same training?
No. That they shouldn't sit on committees or be in positions where they are asked to judge the quality of care provided by a physician because they don't have training.
Yes, that's exactly it. Yeah. There can be some territorial feelings, about that. It just depends, like I said, on the dynamics and the personalities involved, how collaborative they are, how much they rely on APPs, because some of them are like, oh my gosh, I would die without them. I want them here, advising on all of this. And others are like, no, thank you. There's still a hierarchy, if we're being totally honest and real. So I think, I definitely think that's the dynamic.
Yeah, I don't disagree with you that there's a perceived hierarchy. But I think
perceived is the right word. Yeah.
I think that is changing, particularly in smaller hospitals, critical access hospitals, particularly where in some situations and under the conditions of participation for critical access hospitals, a physician only needs to be on the on the ground at the hospital every 2 weeks. They have to be in contact with the hospital more frequently, but they only actually have to be in the hospital every 2 weeks. And you may have APPs that are essentially running the hospital or running the patient care in the hospital. So I think in smaller hospitals where there's a huge role for APPs, then I think there's a lot more argument that a well-functioning medical staff really does need to have more political participation by APPs, or the medical staff falls apart, to be honest. So that will be a really interesting situation to monitor as time goes on, because, we are in a physician shortage. We have been for a long time. APPs, the number of APPs on the ground are increasing, and in some hospitals, there may be more APPs than physicians. So, I think it is definitely something to review as time goes on. So, one of the other really important things to have in the bylaws is medical staff leadership, and a description of the leadership, as you said, hierarchy, Ellie, from accreditation or a legal perspective. There's a ton of flexibility with access hospitals. The COPs say that you have to have a physician performing certain functions with respect to patient care that essentially make them a medical director. And in some hospitals, that medical director is also the chief of staff. But the acute care hospital COPs just say that there has to be essentially a chief of staff function or a president of the medical staff function, which can be an MD, or a podiatrist or a dentist. I guess I've never seen a dentist or a podiatrist be a chief of staff. Ellie's shaking her head, so I'm assuming that you haven't either. But this is something in which you have, a lot of flexibility in how to design the leadership of the medical staff. And my experience has been that you basically have a chief of the medical staff, the MEC, and then you have different, committees flowing down from there. Ellie, I'm curious if you've seen other structures.
No, I have not.
But
It's remarkable. I always say about like how standardized everything is. And, I wasn't practicing at the time, but I think all of that, I actually kind of like, this is really nerdy, but I feel like you would appreciate it, Nick. I feel like maybe you and I could like write some sort of like book or some sort of like thing or history article about like the history of that and why they're like that. Like, was it Greeley? Who was it that created this like set of bylaws that everybody uses from the 1980s? You know what I mean? Like what is this structure and who did it and who's responsible? We got to name this person. We got to like do some research and figure it out because they're all the same, within reason, right? There's some wiggle room here and there, but like with your MEC, with your chief, vice chief, all of those things. I don't know. It's kind of fascinating to me how across the country there are no rules, but yet everybody does the same thing.
Yeah, I mean, I have said in some situations that the medical staff bylaws can almost write themselves by the weight of tradition and history and legal requirements that go into them, right? There's only so many ways to skin that particular cat.
Right.
Melanie, to follow on from Ellie's comment, I'm curious if you've ever seen, non-traditional structures for medical staff leadership that you've liked.
I really haven't. Ellie made a good point. It is pretty standardized without maybe even being intentionally standardized. It's usually always the same medical staff president or chief of staff, vice chief, chairs of the committees. That's usually who makes up the leadership of the medical staff.
I've also seen, and this is actually a variation that I've seen in a number of different places, that in a lot of situations you'll have seats on the MEC that are carved out for department heads. So it's more of a, I guess, representative democracy or a small R Republican style of democracy where you have certain groups that vote for their representative to the MEC who then sit on the MEC and make decisions on their behalf. I've also seen MECs that, have members at large who are voted on from the the body of the medical staff. So there are a lot of different ways to structure it in large medical staffs where there's a lot of departments or service lines or specialties. There probably is a role for a more representative form of democracy as opposed to direct democracy and the medical staff voting for, those people individually. But there are many, many ways to skin that particular cat. Okay, so going on, I do want to touch on quality improvement. So that is also a critical part of the bylaws to ensure that your quality improvement processes are at least outlined in there, although often they're given pretty short shrift in my experience. Bylaws rarely go into detail on quality improvement processes like peer review, FPPE, OPPE. But in your bylaws, do you guys have the quality improvement processes, do you have them outlined in detail, or do you just simply say these are committees which are responsible for these functions or individuals that are responsible for the functions, and they will, design processes in rules or in policies which will perform these functions?
I would say the latter is closer to what our bylaws are. They're outlined, not a lot of detail. That does lead to questions sometimes from medical staff leaders. They'll tell me, well, that's great. We're supposed to do X, Y, Z, but how? How do we get there? What does that even mean? So
just a couple of other things. We've actually touched on immunity, at least with respect to privileging or privileges, or the privilege that's applied to medical staff information and quality information. One of the other things I think is really important to have in the bylaws is a recitation of the statutory immunity that applies to medical staffs when they are doing medical staff work. So immunity from liability for being sued for peer review or those kind of things. Is that something you guys have in your bylaws? Is it incredibly detailed if you do, or is it just a recitation that, immunity may apply?
I do have that in my bylaws. I wouldn't say that it's overly complicated or detailed, just talking about if actions are taken in good faith and within the confines of policies and procedures of the hospital and the rules and regulations that govern that, but there is an immunity afforded. I think it's beneficial because I have had many physician leaders come into their positions feeling like they had to walk on eggshells or be very careful about what they did or what they said because they had heard, I might be able to get sued for this. Are you sure that I can do this? Are you sure that I can review this and say what I'm actually seeing here without getting myself into trouble? So it's beneficial to have that in there for sure and have those conversations with those committees that are participating in reviews on a pretty regular basis.
Well, and it's interesting you say that about medical staff leaders who have heard that kind of thing because, I think this goes to Ellie's point too, that there's a significant weight of urban legend surrounding medical staff work. And that does drive a lot more activity on the medical staff side than you'd imagine it would in such an evidence-based profession, right? Someone has heard something from a friend that happened to them at a place X amount of years ago, and we want to avoid that. And, sometimes that's absolutely appropriate. And sometimes it's like, no, that's not, couldn't have been the way it happened. Or if you dig into the story, it's not the way it happened, or that, wouldn't happen anymore because it happened in 1984. And there have been significant legal changes since that. So, urban legend actually is a really interesting factor in the medical staff world. And that will have to be a chapter in Ellie and I's book.
Yes, for sure. It would be a great one.
Yeah. Okay. So last thing I want to touch on is investigations and the peer review or corrective action process. And I do want to draw a distinction here between peer review in the context of, both are quality improvement, but peer review in the sense of having a medical staff committee review cases that fall out on a regular basis versus peer review in the sense of a true corrective action or disciplinary process. And peer review can encompass both, but it again, from an urban legend perspective, I have found that peer review proceedings tend to be thought of as the harsher disciplinary part, when in fact peer review is a critical part of quality improvement and happens at levels far below the disciplinary process or far less harsh than the disciplinary process. But there really is an important part of having that a robust procedure and a well-established procedure in your bylaws for investigations and corrective action really is a critical part of the bylaws. And so every bylaws that I've seen, every set of bylaws has a section detailing the steps that have to go through for investigations, and then situations in which, the medical executive committee can recommend corrective action, and then a separate one for the fair hearing process, which again, the standard for the fair hearing process can be dictated by state law, but in almost every situation, you want to make sure that it complies with the basic requirements of the Healthcare Quality Improvement Act, which outlines a series of steps or qualifications that your peer review or your corrective action process has to meet in order to ensure that you're covered by the immunity from liability for peer review that's provided by the Healthcare Quality Improvement Act. So a lot of them are pretty standard. And again, to Ellie's point, that probably is wise because they're all intended to meet HCQA's requirements. But in terms of, the investigative process, there is a lot of flexibility in how you design those in the bylaws. And, there's a role for constructive problem solving or, before a formal investigation. There's also different routes you can take in the investigative process. So in terms of constructive problem solving or pre-investigative action, which is ordinarily collegial intervention by other members of the medical staff, has that been a big part of your experience in in the medical staff world. Have you seen that process used in a lot of situations, or is it, rare? Does your medical staff tend to go straight to the investigative part?
We use collegial interventions and some progressive steps like that pretty routinely. When we did our big revamp a few years ago, the process kind of changed, like who's going to review initially and who's going to make that determination. But since we've gotten the new process down, and our leadership committee, our medical staff leadership committee, is who reviews most of the initial issues and makes the determination, it's gone really well. Collegial interventions solve a high percentage of problems that come up in the medical staff without ever having to go to that investigative or a deeper dive into issues that are occurring. And I've had it come up even at survey. I had just last time we had surveyors here, they were reviewing incident reports that the hospital had received. There was a particular physician's name that came up, and surveyor asked then when they came to do the medical staff review, she wanted to know all the details about what that investigative process looks like and what we did about this. And we were able to clearly articulate to her, here's what our process is. These are the progressive steps that we take. This was one that we just did a collegial intervention. We assigned another physician as kind of a mentor to help guide and work with that physician to prevent any future issues or frustrations that were leading to the issues. And the surveyor was actually really impressed with that, the process, and that we had it documented and that we were able to show how that collegial intervention had helped and potentially solved the issue before it ever got to.
So who does the collegial intervention under your process? Is it the chief of staff, or does the CMO, chief medical officer, have a role? I'm curious.
It can be any of those people. It is often, so we're organized in service lines instead of departments, but it's usually either the service line chair, or it can be the chief of staff, and even the CMO. It depends. Like if it's an employed provider, sometimes it's the CMO on behalf of administration and kind of bridging that gap between this could get you in trouble on the employment side of things as well. And it's also been brought up with the medical staff. Sometimes the CMO isn't appropriate. So it depends. But the way that it's outlined in our policy, it can be any of those people. So the medical leadership committee will talk about it first. They'll decide who the most appropriate person is, depending on what the issue is, do the collegial intervention, and then they report back to me or back to the committee at the next meeting so that we have record of that for future if needed.
So it always starts with the medical staff executive committee, or whatever that medical staff committee is, and they can assign it out to different individuals depending on the circumstances. Is that right?
Yep. It's called in ours the medical leadership committee. It's a subcommittee of MEC, and just a handful of the key leaders, and they'll discuss those issues and then assign them out as needed to whoever's most appropriate.
I like that idea of involving the CMO, because in a lot of situations, the CMO kind of sits in a bit of a no man's land because they're always a physician, and often they're a member of the medical staff, but they don't usually have a firm role in the bylaws to do a lot of medical staff things. And I really like how you've identified them as a leader in the hospital that can do those kind of collegial interventions under the auspices of the medical staff. But I'm assuming they're still not a medical staff officer. Is that right?
Correct.
Yeah. So, I really think that in a lot of situations, medical staff bylaws should acknowledge a role for the CMO. They don't always. And I think that is a missed opportunity in a lot of situations, because it kind of leaves them in a no man's land, and it can foster some, I don't know, I want to say sense of competition, but just confusion between the chief of staff and the CMO, between who is responsible for certain aspects of medical staff, corrective action or collegial intervention or quality improvement, those kind of things. So I think that's a great way to thread that needle. I really like that. I was going to say skin that cat again, but then I was sure it would attract a few to complain. So I like thread the needle better. Okay, well, so that really is, kind of a shallow dive into the medical staff bylaws and elements that should be included in it
or in them. I mean, as I think to wrap up, the medical staff bylaws really are a critical foundational document, and there is no one size fits all. I think you'd agree with that, Melanie.
Yeah, absolutely.
And it really does take a lot of consideration by the medical staff in conjunction with other stakeholders, including administration and the the governing board, whether it's the board of directors or trustees or whatever it is, as to what should be in there. Ultimately, it comes down to what, in most situations, the medical staff and the board of, the governing board decide is appropriate. But there's a lot of stakeholders in the processes and principles that are outlined in the medical staff that really do need to be carefully thought out. And, simply adopting a set of bylaws from another institution is rarely the right idea, in my experience. I think it really does require a lot of careful thought. So with that, Melanie, I really want to thank you for taking the time to be our special guest star today. Your perspectives have been really invaluable. And I really want to thank Ellee for her contributions. She has a wealth of experience in medical staff issues, and I really enjoy working with her. So I'm grateful. Hats off to both of my special guest stars today. And I guess I want to thank everybody for tuning in to Beyond the Bylaws, Husch Blackwell's Medical Staff Podcast. And we will see you down the road. That was fun.
That was fun.